So Dr. Melissa Kremer earned her Doctor of Psychology and Clinical Psychology from Adler University in 2012, with a concentration in trauma psychology. She completed her pre-doctoral internship at the Boise Veterans Affairs Medical Center. Her research, clinical interests, and area of expertise include trauma psychology, military psychology, end-of-life concerns, and evidence-based psychotherapies for PTSD. She is currently the PTSD Clinical Team provider at the Boise Veterans Affairs Medical Clinic and has been there since 2011. She also serves as the Telemental Health lead for Boise Behavioral Health and provides training and consultations around telemental health for providers. And somehow she still makes time to volunteer with several organizations in the Treasure Valley. We're so happy to have you here. So I'm going to hand it off to you now. Thanks again.
Thank you. I'm going to play this slideshow now. So if somebody could just type quickly in the chat box, just let me know if you're seeing this. Potentially. Looks like the little chat box went away. I
just see a white screen real quick.
What?
I just see a white screen, so you know.
Huh, okay. Is it showing it better?
Yeah, I can see it now. I can just see the little, like the play table chart text sign too, but I can still see it. So.
Okay, I will put it on full screen and play and see if that helps better.
That's great.
All right. Thank you everyone for joining today. As introduced, I wear a lot of hats at the Boise VA. I'm really grateful to be there and grateful to be able to be doing outpatient outreach and just different events within the community. And I have to do my little disclaimer at the beginning, as always, that all of the opinions and information presented herein are mine and not that of the Boise VAMC or the federal government. And just the standard disclaimer on that. I'm hoping that this information is helpful for a lot of you, and I'm assuming based on the fact that this is the provider webinar, I'm not going to dive totally into all of the diagnostic pieces because y'all are good at that, and that's part of what you do. So we'll touch on that a little bit, but focus more on Idaho veteran statistics, Idaho veteran stuff specifically, and the military culture and its impact. So please ask questions as we go. Anna's going to be monitoring the chat box for me and taking that information into account, and we'll have time for questions at the end. Also, my other disclaimer is that I am a PTSD provider, so that section of this program is going to be a little bit more detailed than the other sections, not because I don't value major depressive disorder or substance use disorders or other types of treatment, but simply because PTSD is kind of my jam, and that's what I have my passion for. So without further ado, let's talk a little bit about impact of military culture on mental health treatment. So for today, I want us to objective-wise just review PTSD, MDD, and SUD, understand different cultural aspects of symptom presentations, and gain knowledge about treatment modalities, specifically VA resources. Because again, that's kind of my wheelhouse and where I'm at. I know a lot of you are coming from different organizations. I think Anna mentioned there's some health and welfare folks, and there's some St. Luke's folks, and some BSU folks, and ISU folks, and I'm sure some other ones that I didn't add. So if you have additional resources, feel free to share those as well within the chat box. So specifically looking at veteran population trends, this is something that I think is something important to discuss and worth noting. The total veteran population is predicted to decline from 20 million in 2017 to 13.6 million in 2037. And this is partially because we're an aging veteran population, but also because the percentage of folks joining the military has really dwindled comparatively. In World War II, it was about 11% of the population served in the armed forces. It was down to about 7.6%-ish in the Vietnam era, which was our last time of the draft, and now we're at just about 1% of the population serves within the armed forces, and even within that population, the population that deploys within the armed forces is less. And so you're seeing this trend of multiple deployments and the stress that that puts on families, the stress that puts on our soldiers and our airmen and our Marines and our Coast Guards and our sailors. So the percentage of folks serving the military is much different, and that number is going to continue to decline. So beginning in 2016, the Gulf War era vets actually became the largest veteran cohort, which even with me being in the VA, that even caught me off guard. So nationally, there are 7.2 million World War II era vets, 7.2 million Gulf era vets, 624,000 World War II era vets, and that number is pretty significantly declining every year, as you would imagine. 1.475 Korean era vets and 6.65 million Vietnam era vets. In terms of the stats of veteran population, 50% of veterans reside in 10 states, and the trends right now is that veterans are moving to the west and to the south. California and Texas, not surprisingly, have really large veteran populations. They're in the top 3, and Florida is also pretty significant for veteran populations, and they're slated to move up to the projected #1 population state by the 2030s. So if we look specifically at veteran statistics in Idaho, we have a total of just over 123,000 veterans. That's about 1,400-ish veteran increase from our last set of data. Not surprisingly, the statistics within the government are not wholly up to date. So in terms of what I could find, I found FY16 data, and so that was from FY15 to 16, it went up about 1,000. In that, it went down almost 1,000 of our World War II vets. So our increases were in our younger veteran population. So we had about 96,000 wartime vets, and you can see the numbers for Gulf War, Vietnam era, Korean conflict, World War II, and so on. Our male veteran population actually declined between FY15 and 16, and our female veteran population increased. Here is a veteran population by county fiscal year breakdown, just so you can see kind of where things are at for FY15. You can see that people were definitely around a lot more urban areas, which is not surprising. Here in Idaho, we have a highly rural location, although you can see there's a few areas here in eastern Idaho and Spokane and Coeur d'Alene area where the population was a lot higher. So specifically looking at Idaho community stats. So we have Veterans Justice Outreach folks here at the VA. We have 3 folks that work in our Veterans Justice altogether, and our numbers for incarcerated vets in Idaho are pretty consistent with a national average. About 8 to 10% of the inmate population at any one given time are veterans. We do have vet courts in Ada County, Canyon County, and Twin Falls, as well as Malheur County in Oregon. When we look at our homeless veteran population, this has been one, our homeless veterans and veteran suicide rate are 2 of the top priorities nationwide for Veterans Affairs, as well as just community-wide. So over 220 HUD-VASH vouchers are in place within our community, which is an increase from the year before, and the numbers of our folks served through our homeless team almost increased 50%. And we have a ton of amazing community partnerships. We couldn't do a lot of that work without our community partnerships. So if anybody's from any of those, from the VA, we appreciate you. Our LGBT population, there's also not a ton of data on this specifically within veteran and especially within Idaho population, but in terms of overall Idaho community, just over 36,000 folks in Idaho per a national survey identified as LGBTQ, which is about 2.8% of our population. VA healthcare has moved forward leaps and bounds over the last 5 to 10 years in terms of what they work on for this population. Treatment includes hormone treatment, SUD treatment, STD treatment, and preventative work, IPV, so intimate partner violence treatment, heart health, cancer screenings, prevention, treatment, all of those things. One statistic that I found that I thought was of note to be interesting, the Pew Research Center did a survey in 2013, found that 21% of LGBT respondents within Idaho felt that they'd been treated unfairly by an employer in hiring, pay, or promotion. And in 2010, 78% of respondents to the largest survey of transgendered people reported experiencing harassment or mistreatment at work. You guys know that Adler words and that movement has been pretty prevalent for a while within our state, and we can see that research here. Again, as I mentioned before, talking about suicide, specifically with the veteran population, has been a national topic. A lot of people know the stat of 22 veterans per day. One of the challenges with that is we look at how many of those are involved in VA care, and usually about 60% of folks aren't involved in VA care. So for us, within the VA, our passion is really how do we do a lot of this community outreach? How do we get people engaged in care, whether it's with us at the VA, whether it's in other organizations that we can partner with, so that we can work on this and get people engaged in care and they don't feel like they're fighting these battles alone. So in 2017, Idaho did have the 5th highest suicide rate in the US, with a rate of 22.9, which is 58% higher than the average. Our suicide prevention coordinator, who I believe is on this webinar today, her name is Mary Pierce, she's one of our 2 SPCs, did a little math for me, and we found that in 2017, in terms of the suicide rates in Idaho, 12.47% who died of suicide were veterans. So that's definitely lower than the national average. In terms of veterans, we do have high numbers for suicide, again, in Idaho, but we're hoping that indicates that perhaps there's a little bit of trend that our suicide prevention work is working, and we'd love to see that trend continue. And, unfortunately, suicide is the 2nd leading cause of death for Idahoans ages 15 to 34, and for males up to the age of 44. Specifically, a little bit about our Boise VAMC. For those of you that don't know kind of numbers-wise what we're looking at. So our FY19 numbers, so these are our most recent numbers per our annual report from the hospital. We had 38,740 enrolled veterans, which was an 8% increase from the year before, with almost 420,000 outpatient visits, which again is a 9% increase. So we're trying to see as many folks as we can. Our catchment area does include a little bit of Eastern Oregon, as well as sometimes a little bit of folks from Washington, and we see some folks from Eastern Idaho as well, although technically their catchment area belongs to the Salt Lake City VA. So we had 117 unique vets. Uniques are just our hospital's word for talking about individuals. So 117 individuals identified as high risk for suicide. We do some additional tracking on those based on some algorithms and metrics, making sure we're treating those folks and kind of looping them into services. We had 71 reported suicide attempts and 11 reported suicide completions, and over 1,300 unique homeless vets were serviced by our homeless team, which was an increase of 740 from the year before, which is a pretty phenomenal jump in services. So one of the big things we're going to be talking about today is military culture. So I wanted to start by talking about this kind of as the way that we do this is the lens for moving forward. I will always give the disclaimer that I am not a veteran myself. I am a military spouse. My husband is part of the Idaho Army National Guard, so I get to see that whole part of Gowan, not only from the clinician perspective, but also from the wife perspective. So those are my filters moving forward on this. So again, I don't claim to have a veteran background myself. One of the things that we see in terms of military culture is that the military training encourages toughness, courage, and denial of emotions. There's really that no pain, no gain approach to this, and that starts pretty immediately from basic training. A lot of people sometimes have a perspective of basic training that it's really about breaking down the individual for the purpose of breaking them down, and it's really about there's an aspect of that, and it's about getting them to the point where they can be really inserted within a team and working within the mentality of brotherhood and sisterhood, and really taking that team-based approach. So fear, pain, and emotions are signs of weakness. On my next slide, I talk about a few of the phrases I hear pretty frequently, and emotions are for namby-pambies and things like that are a big part of that, and that creates a pretty significant framework when you think about looking at behavioral health symptoms and how that may or may not impact an individual's perception of if they can even look at healthcare options, behavioral healthcare options, or even if they're willing to admit that there are things that are challenges for them. Stoicism and the ability to conceal emotions and outwardly seem indifferent to hardship, pain, and grief is really viewed as an important leadership characteristic. So when we have folks that continue up the ranks and are looking at careers within the military, we often see this approach kind of continuing higher as they continue to increase higher within the rank structure. All of this does have a little bit of shift between the branches. It has a little bit of shift within the last couple decades with a lot of the media coverage of challenges for veterans. But still, there are things like concerns about job stability and or security clearances if people seek treatment. And so for folks, there's a lot of these different aspects of job security that play into whether they feel like they can even acknowledge behavioral health concerns, let alone seek treatments for them. One of the additions that we've seen in terms of folks coming in specifically with military sexual trauma, because there has been so much media surrounding this and changes within reporting and things like that, there have been in the last, I believe, within the last 5 to 8 years is when they started changing the way specifically that you can report military sexual trauma. You can choose to do either a restricted or unrestricted report, and this change came about because a lot of people wanted to get to the VA, wanted to work on some of their trauma stuff, and had never reported anything because of some of those concerns about job stability I'd just spoken about a moment ago. And the response had been, well, there's nothing in your record that indicates this. So from the regional office side of the house, there were a lot more people that were denied service connection and felt like they couldn't talk about this, or they couldn't have this be acknowledged by the VA as part of their experience. So they changed the reporting approach. So you can do either a restricted or an unrestricted report. A restricted report is that you are documenting that you're going in to seek medical treatment after any kind of military sexual trauma. You're getting treatment for that, whether it be within a community ED or on base, and it's being noted anonymously as an indication of some kind of trauma, whether it's assault, whether it's rape, whether it's unwanted touching, whatever it might be. It's indicated or it's reported anonymously, but it is in your service treatment record. An unrestricted report has the potential to start a JAG investigation, and your command structure is looped in on what's going on, and it's reported within the legal system. So that is a little bit of a thing that has changed within military culture in the last 5 to 8 years in terms of reporting specifically military sexual trauma. As we continue to talk about cultural implications, I wanted to kind of include some of the phrases we hear a lot, or at least I hear a lot. I can't speak for every VA provider, but sometimes when folks come into us, there's a cultural piece of, you just don't get it. You're not a veteran, you weren't there boots on the ground, and so you don't understand. This can be a really firm kind of boundary for a lot of folks in terms of seeking treatment. We do have our vet center, which is staffed with a number of veterans, and within our behavioral health service at the VA, we also have a number of veterans who are on staff as well. This is also a form of avoidance in terms of seeking treatment, because you're looking for that aspect of the person who's had an identical experience to you, which even if you have somebody standing next to you in a firefight, they're still going to process it and experience it a little bit differently. That is the lens that I use when I talk to folks and say, you're right, I have not been in combat. I haven't been downrange. I never deployed. Here's what I do know, and here's where my experiences come from, and I'd really like the honor of being able to work with you, and here's my hope in terms of what we can do together. I also hear the emotions are for namby-pambies, things like that, things like proper planning prevents piss poor performance. And these really, a lot of these phrases, a lot of these ideas really cement the idea of control, whether it's control of everything around you, whether it's control of emotions, whether it's outward control of your soldiers, whatever it might be. That command structure and hierarchy really implies control and its importance for that. And that has a lot of impact in terms of behavioral health symptoms, especially when they feel like emotion regulation is a struggle for them and they're failing at controlling their emotions or their drinking or whatever may be impacting their life and their functioning. One of the things that I always like to bring up in terms of military culture is also some of the more recent research regarding suicide and why there may be higher rates of suicide within the military. Again, I'm not speaking in terms of causation, but perhaps just some correlative factors. One of the research trends that has been popping up recently is part of not committing suicide is that, innately we have a fear of death. And that fear kind of is a protective factor for us in terms of suicide attempts. And when you go through your military training, when you get to the point where you have your training, you're ready for what you're setting forth to do, part of that training is to really work on the fear of death and not have that fear. Part of joining the military is signing that check, which can include up to the cost of your own life. And when you don't have that fear of death, that may kind of lower the barrier for some folks in terms of their comfort level of suicide. And again, it's not a cause in terms of suicide, but we're just looking at correlations in terms of what we may see that folks end up having a little bit more of a comfort with that. And if they then have some suicidal ideation, that protective factor isn't there for them. Another huge cultural implication of the military is that of alcohol. Starting from pretty early within the majority of people's military experiences, I hear a lot about binge drinking. As a spouse within military cultures and engagements, it's about binge drinking a lot of the times. And so when that culture is supportive of alcohol, that becomes kind of inherently a coping skill that is reinforced by the military, and then people take that coping skill moving forward when they have not as much structure that they do in the military, and it often becomes problematic for a lot of people. I often remind people to look at what is around active duty installations. You will quite often see bars and car dealerships for sports cars and motorcycles, specifically folks driving really fast or driving new shiny trucks. So bars, car dealerships, pawn shops, bail bondsmen's, strip clubs. And so that kind of culture of partying and excess and adrenaline seeking often continues right outside of our active duty military installations. People will often joke with me that they came back from a deployment and they got a PowerPoint presentation that said, all right, you're back, don't spend all your money in one place, don't beat your wife, don't try to drive too fast, don't buy a new motorcycle. Again, paraphrase, but when people are sitting through PowerPoints, they just kind of want to get going with things. And so I think the military realizes that some of that culture is in place. I think all of these are part of the lens through which people then come in to see us. And so for these folks, for veterans, that culture and that filter through which they approach things, I think impacts not only their symptom presentation, but also how they attempt to access care. I also like to point out, and I do this a lot when I talk about hospice and end-of-life considerations, that within our idea of patient-aligned care teams, which I know is what the VA is moving towards, and I know a lot of outpatient facilities use this perspective as well. Within the patient-aligned care teams, there's really this perspective of interdependence, connections, and open team approach, and self-determination, choice, advocacy for yourself, This may be very foreign to somebody who's just come out of the military, been in a culture of dependency. We have rules and regulations for everything, down to what kind of socks you're wearing and how your haircut is. And so going into a different kind of culture may seem foreign to folks. Again, the military is that hierarchical organization. And so people are like, okay, I'm used to you telling me where to go, when, and what I need to do. And when we're saying, hey, you know, when would you like your appointments? Would you like to be working with this type of provider? Or, you know, do you think that maybe adding some physical therapy for this would be helpful? Or should I do a referral to the PTSD Clinical Team? That may seem a little foreign to folks who are used to, you know, giving orders, following orders, and that culture of stoicism and downplaying suffering. So again, another thing to think about when you look within your organization and how teams are structured. So now I'm going to switch gears a little bit, just talk about PTSD, some clinical treatment approaches to PTSD, a little bit of assessment stuff, and major depression disorder and substance use disorder. And then I really want to make sure that at the end we save time for questions for folks about how they, what questions they may have about military culture and what questions they may have about how it may impact presentations for individuals that they see. Within PTSD diagnosis, there's 4 symptom buckets. We're looking for intrusion symptoms, so intrusive thoughts, flashbacks, nightmares, persistent avoidance of stimuli associated with a trauma, so that could be avoidance of people, places, and things that remind them of trauma, and avoidance of thoughts and emotions. Negative alterations in cognitions and mood, that's that new symptom bucket that just came in the last DSM, the 5, and that is the piece of really kind of pulling out depression affect and those negative self-talk things, the self-blame, the guilt, things like that. And then the alterations in arousal and reactivity, so hypervigilance, startle response, jumpiness, anger and irritability, recklessness. So PTSD changed a little bit in terms of DSM-5 where it was grouped. A big criterion or a big change in terms of the criterion I want to note for veterans and military culture is the changes in criterion A. So in my past life at the VA prior to what I do now, I was doing compensation and pension exams. We did a lot of work around PTSD diagnosis and what that meant for folks. In the past criterion A, you had to have fear, the intense fear and helplessness or horror around that in terms of a criterion A. And I would talk to people and they're like, Doc, I'm just doing my job. I didn't have those feelings. I was doing what I was trained to do. And honestly, some of the work I do with folks ends up being about feelings about, hey, I had excitement about being able to do what I was trained to do. And yet what I did wasn't really kind of jiving with my morals. So for folks with that criterion A in the veteran world or the military world, it was a little bit different. So they've made some changes and you don't have to have that helplessness or horror now for the diagnoses. There's a ton of PTSD assessment tools. National Center for PTSD recognizes almost 70 measures. A lot of them are self-report measures, so they're face valid. You have to be kind of aware of that when you're meeting with somebody. We look at that in the VA, just making sure that if people are also seeking a disability claim, that we're taking that into account, whether they're looking for Social Security disability or a service connection pension through the VA. Some really good basic overall assessment tools would be the CAPS, Combat Exposure Scale, the Mississippi Scale for PTSD, and kind of our bread and butter, the PCL-5, the PTSD checklist. When we do more comprehensive measures, we will often add in some effort measures. We'll add in some cognitive measures to kind of see what's going on for folks, some personality functioning measures as well. Lots of types of treatment, and honestly, some of these types of treatments I'm going to be talking about are also going to be similar to the types of treatment for major depressive disorder as well as substance use disorder. So I did a whole huge list here, and then I'll kind of touch on them again as we go. So cognitive behavioral therapy, and kind of under that umbrella, cognitive processing therapy is one of our evidence-based treatments for PTSD. Prolonged exposure is one of our other evidence-based treatments. EMDR is not currently noted as one of the main EBPs for PTSD through the VA. That does not mean that it's not a relevant treatment. We have some folks at the VA who are trained, and I know we have some folks within the community that are trained as well. ACT, acceptance and commitment therapy, again, not specifically noted by the VA as an EBP for PTSD, but a really important and valuable treatment, specifically for veterans with depression. It's definitely something that helps there, but really across all, whether it's PTSD, whether it's major depressive disorder, whether it's substance use disorder, there's a lot of aspects that go into that. Supportive types of therapy, looking at psychosocial stressors and relationship impacts. Treatment modalities for all of these that I'm going to talk about include both in-person and telehealth. We at the VA have really been working on expanding our telehealth options, whether it be groups, whether it be individual. They can do telehealth to a CBOC, one of our community-based outpatient clinics, and we also can do individual telemental health services into the home. One of my plugs on that is that it really allows anywhere access. So when we look at folks and we want to get them in as quickly as possible and we want to get them consistent treatment, I can see a trucker for a 12-week course of CPT, and I can see him. I get to know a lot of truck stops throughout the country because I get to see a lot of folks that way, and they find Wi-Fi at different truck stops. We do a 90-minute CPT session. They get out of their truck, they walk around, kind of ground themselves, and then they can get back on the road, and it doesn't impede them in terms of just getting in for treatment when they are happening to be in town. Again, we do groups, PTSD groups, insomnia, pain groups. Any one of these types of modalities, that lens of how the individual is presenting, whether it be the hesitation of, I don't want to talk about this. We get from some folks, I can't talk about this. What I did was confidential. I personally, my approach to this tends to be none of our treatment in this room uses a map, coordinates, grids, etc. And there are a ton of amazing veterans in our community who were spec ops across all branches of service. And there are also a lot of people who may not have been, and it's part of their avoidance strategy as well in terms of not wanting to talk about their treatment. So that's something within the individual relationship that you have that really needs to be sussed out. We see folks really downplaying a lot of what's going on for them. I don't need treatment. These things aren't going to work for me. There's no way I can talk about my emotions because if I start talking about one thing, everything's going to flood. So then you use your clinical acumen that you have in terms of rationale for treatment, in terms of building rapport. I find that with a lot of the referrals I have for folks who don't have a lot of experience with talking about emotion, with really opening up with anything outside of kind of that cultural norm for them of emotions are a sign of weakness, it takes us an additional 3 to 4 sessions of a lot of foundational work to really be comfortable at a point where they can dive into clinical work at a level that would be beneficial for them rather than just being surfacey and saying, no, I'm fine, everything's good, I'm not going to feel my emotions, I'm just going to show up and tell my therapist what I think they want to hear every week. I tell people I'm pretty straightforward and I call it like it is, and I will call people out if I see avoidance. I tend to find, at least from the veterans I work with, that straightforward approach really matches a military cultural approach where you can call each other out and be, pretty gruff. And so from that aspect, I find that me taking that approach to the treatment is actually pretty beneficial for them. I talk a little bit about PTSD in older populations, mainly because of my information from the earlier slides that our veteran population is really declining. And so many of our older vets are getting their treatment within the community. So realizing that, aging is a process that begins, it's not something that, just begins, when you hit some number, whether it's 75 or 80 or 85 or 90 or whatever it may be. I don't know the ages of everyone, so I hope to not offend anyone. It's a lifelong process. There's a lot of times where that dying process can be a trigger for folks in terms of their PTSD, and we can see that worsen as they get older. Their health decline is happening, and they've used physical abilities to really kind of modulate their emotions for a lot of years. It's been their way of kind of dealing with their PTSD. Again, that's more consistent with the military culture of, we can talk about physical stuff, we just can't talk about emotions. And then when their body starts to break down, when they have the injuries, when they have the natural aging, and all of a sudden their body can't do what they want, that really gives their brain space to kind of start popping up all that emotional stuff. And we hear a lot of, I should be over this by now. I don't know why this is popping up 40 years later. I'm a failure because I can't deal with it on my own. So realizing how that cultural piece of, we can deal with it physically, just not emotionally, could impact things. Also, aging gives us a natural decrease in our memory skills and abilities. And when we have less cognitive juice and less abilities, we have less kind of strength there to push all of our emotions away, and stuff might start popping up in older populations, especially when we see dementia or when we see cognitive decline. Additionally, you may have that combination of avoidance, mistrust, and increased health concerns. You may have people who feel like they're being forced into care by loved ones, and that presents a whole other kind of flavor to your treatment that you work with, whether they feel like they're there willingly or it's forced. Not only do we see that with sometimes older veterans, but also court-ordered treatment around our SUD work, and people feeling like something's not a problem for them, but they have to appease a judge or a PO by coming in for treatment. Again, depression criteria, they need to have depressed mood most of the day, nearly every day, that markedly diminished interest or pleasure in activities, so that anhedonia, significant weight loss or significant increase in appetite, loving all those carb-heavy dishes or stress eating, either slowing down or really increasing that sense of jitteriness and that restlessness, fatigue or loss of energy nearly every day, the worthlessness or the excessive or like inappropriate levels of guilt. Again, that's kind of similar to that third criterion for PTSD with the negative cognitive appraisals. Diminished ability to think and concentrate, and recurrent thoughts about death or recurrent suicidal ideation without a plan or attempts. Again, my lens is PTSD treatment mostly. I see a huge Venn diagram overlap here with folks. When we're looking at specific major depressive disorder treatment, anything within the CBT, the cognitive behavioral therapy field, is really kind of aimed towards this. There's specific ones for brief interventions, there's specific ones for couples, different things like that. ACT is really phenomenal in terms of targeting depression specifically, and it is an evidence-based treatment for depression, for veterans with depression through the VA. Psychodynamic approaches, kind of doing some of that approach is part of that, as well as humanistic and Adlerian. There's a whole bunch more, and I would never be able to hit on all of them. There's also a lot of emerging treatments for depression. There are some VAs that do these. I know there was a 60 Minutes thing on the stellate ganglion block, which is something that is traditionally used as a migraine and a headache treatment, and has been found to be effective in some folks with really treatment-resistant PTSD. And there's some research going on in a couple of VAs around this. And when the 60 Minutes special ran, we got a lot of calls. I know locally there's a few clinics that do TMS, the transcranial magnetic stimulation. I know I've seen a presentation. I knew at least one works specifically with depression and another works specifically with OCD. And so there's some evidence around that, as well as kind of biofeedback and things like that. There's other FDA approved meds coming down the pike, whether it be ketamine, whether it be marijuana trials or other types of trials. I know we tend to get a lot of questions about this, and I'd be curious to know kind of some of the questions you guys get. I have seen a shift over the last decade, that almost decade that I've been at the VA. Early on, there was a lot of folks saying, I'll never consider illegal drugs or drugs that used to be illegal, although at one point in time with prohibition, alcohol was illegal. And just a really kind of a firm rooting in, these are my morals and values. I was raised, I was raised this way, or the military kind of reminded me of the importance of pride and regulations and laws. And I've seen a little bit of a shift in that, not to say that every veteran comes in wanting medical marijuana or ketamine or other types of treatment, but there has been, as states have legalized throughout the years, there has been a little bit of shift in that cultural approach. That being said, we live in Idaho, where those types of substances are not legal, and as a federal employee, that is our perspective on things, that you need to be engaging in legal treatments. ECT also exists if people are really treatment resistant for major depressive disorder. There is a lot of memory and health implications that can be involved in that. So as with a lot of hospitals where this is provided, there's a panel of doctors, and this isn't a decision based on one provider. There's a panel of the doctors, and they look at ethical concerns with something like this. Just a little bit of difference with SUD, substance use disorders, just in the difference between dependence. So when folks have dependence, there's symptoms of tolerance and withdrawal. You can have dependence without addiction. It usually means addiction is right around the corner. And addiction is marked by change in behavior by the biochemical changes in the brain after a prolonged and continued substance abuse. There was no way that I could list everything in terms of the different types of substances that can be abused. I will wholly and readily admit that I have learned so much working with our residential treatment facility about substances that I didn't even know existed. I didn't have a lot of knowledge about kratom. I didn't have a lot of knowledge about spice or bath salts or things like that. So when you look at the different types of things that can be part of substance use disorder, I encourage you to do a lot of research specifically around what your folks are telling you. Again, military culture wise, alcohol is one that I usually see where folks are saying, hey, this is part of what we did. This is our norm. For the Marine Security Guard folks, every Marine Security Guard home has to have 2 fully stocked bars by law. So again, that cultural acclimation and norm around binge drinking and alcohol. So looking at how that impacts things. At the VA, we have both inpatient and outpatient modalities. We have an outpatient intensive program, so people come in 5 days a week for outpatient programming. There's also the residential programming. Community self-help groups are huge, whether it be NA, AA, Smart Recovery, Celebrate Recovery. There's one that's more of a Buddhist slant, and I can't remember the name of that off the top of my head. There's also an increase in medication-assisted therapies, whether it's looking at Suboxone, whether it's looking at methadone, medication-assisted detox, all of those aspects. Again, often from a military culture, it's kind of like, okay, I'm being given something, I'll take it. So sometimes people more readily are amenable to medication or availabilities rather than talk therapy options, because again, that emotional piece of things. But it often comes down to just trying to figure out motivational interviewing and buy-in and things like that to make sure people are wanting to make changes. I could continue to go on, but I also am cognizant of time, and I want to make sure we leave at least about 15 minutes for questions. And so I have a couple sources slides if people have questions about that, but I am going to now open us up question-wise to Anna, please. I don't see a chat box, so I don't know if people have been asking questions, but I want to open it up for questions at this point in time.
Okay, so there are quite a few, or there's just a few questions, so I'll go ahead and just read them off to you one by one, so you can kind of go through and answer.
Let me see if I can. I don't know how I could make the chat box
Yeah, I'm unsure
open on my screen. Go ahead.
perspective, but okay. So from Brian Anderson at 12:08 p.m. So this may have been answered throughout, but do we have any stats on OEF, OIF vet cohort size?
Not in terms of the vet data that I was given. I have seen some like embedded in different reports, but not off the top of my head. I couldn't give you stats on the OEF, OIF, OND culture or group size within Idaho.
Okay, thank you.
It's definitely growing. It is definitely a growing population because we continue to be engaged in the Middle East at various levels of engagement and locations. And Idaho is a very veteran-friendly state.
Awesome, thank you. Brian Anderson also asked about resources or a list of sources for this research, which you have posted on your slides. So those are available for all of us. Sean Dugan shared a resource that the VA published on acupuncture with some more information. So I know that Sean is an acupuncture provider in our community. So he had mentioned to me earlier about
yes,
acupuncture.
Through our integrated spine care clinic and chronic pain work, there is a lot of work on, treatments outside of just medication treatments. So whether it be cognitive behavioral therapy for chronic pain, there's specific yoga groups through the VA that are kind of adapted and targeted for chronic pain. There's also community care consults for acupuncture and chiropractic work, which the VA recognizes as helpful as well for folks. And I think some folks have gotten Blue Cross, Blue Shield to cover massage, but I do not believe you can do massage work through the VA.
Awesome, thank you so much. Lawrence Carson's question, and it's a long one, so I'm just going to go ahead and read it real quick. I'm wondering if some of these PTS release tools could be taped and put on YouTube so veterans not wanting to be, quote, found out can watch, learn, try out on themselves, and then perhaps get themselves an emotional willingness to go to the VA for active PTSD remediation treatments. What do you think?
So I think that that's definitely something that could be a possibility. For me, I want to make sure I kind of have eyes on. I'll be honest, for me, I'm so used to with Telemental Health seeing my patients. So for you guys, not seeing anybody while presenting is a little odd for me, and I've been having to kind of be aware of that as I've been going. So for me, my first response would be I wouldn't necessarily want to do a lot of clinical diving in work, but things like breathing and mindfulness and things like that that really kind of help people in the beginning steps of some emotional regulation. There are some interesting YouTube videos about things. The National Center for PTSD website has some good videos. There's a whiteboard video on PTSD that explains it in a way that's often helpful for families and even for folks who aren't really kind of making sense of what's going on for them. And they have some videos about treatment as well.
Awesome. Okay, let's scroll down. Brennan Anderson asked, does the Boise VA Medical Center support any local CBOCs?
We have multiple CBOCs. So we have attached to our Boise VA is a community-based outpatient clinic in Caldwell. We also have technically, I think some of the smaller clinics have a little bit of a different name. I call them all CBOCs, but so we have at Caldwell, we have Mountain Home, we have Twin Falls. Technically, there's actually 2 clinics in Twin Falls, but they're all under the umbrella of the VA CBOC. Also Salmon and Burns, Oregon. So those are the affiliated ones with our VA.
Okay, thank you. Next question is from Sean Dugan again. He said, I'm curious if veterans are being referred to acupuncture for PTSD here in Boise. Okay, yes, I only see referrals for pain. So yeah, if people are being referred for acupuncture for PTSD.
So within our kind of referral window in terms of community care consults, the VA does have kind of a protocol around that. So this point in time, I believe that the primary referral source is chronic pain, but throughout this program, I welcome anybody to reach out. Anna, feel free to make my VA email available to folks, so that if you do have questions or concerns or information that you'd like to pass forward, I can do my best to kind of forward it up the chain. But in terms of what I know in our current referral sources or protocols, it's primarily for chronic pain.
Okay, thank you. I'm going to put your email in the chat box for people to just kind of access if they want it. We have a few more quick questions. Let me get those for you. So we have one from Athena Evans Campbell, and it said, she just said, any use of iRest?
So I don't use it personally. You know, kind of some of the treatment like EMDR would be using some more of the eye movement stuff. I know that there's been some research around it. I'm not as familiar with it individually, so I don't use it.
Okay. We have a question from Matt Harden that says there are 7 state-funded 24-hour crisis centers to help anyone, including vets experiencing a mental health or SUD crisis. 5% of our clients in Pocatello are vets. We are constantly looking to increase those numbers. How can we reach out to the vet population better?
I would say, especially in Pocatello, there's a few CBOCs that are associated to the Salt Lake City VA. I would touch base with the behavioral health providers there, as well as perhaps seeing if you could get in contact with the behavioral health staff down in Salt Lake. I know Dr. Carol Berndt, who is our ACOS, our Associated Chief of Staff for Behavioral Health, kind of my boss's boss. Dr. Berndt has been active in terms of the community and knowing what resources are available, sharing that with us about locally here in Boise are the crisis centers that are available, and I believe they can do, you know, 22-hour, 30-minute stays or things of that nature that aren't considered a mental health hospitalization. So the more you can kind of reach out to some of the providers, the more they would be able to know what resources are available. Often, the CBOCs as well as behavioral health, we have bulletin boards in behavioral health as you walk into our building that we can put various things on, and people will often advertise different things there as well, so that information can get out and about.
Awesome. And looks like we have a response from Brian to Athena's question about iRest, and said the VA just sent out an email offering free sessions of iRest for vets recently. So just verbalizing that out loud. And then Brian Anderson, what was that?
There is a little bit more involved in our women's clinic. We have some folks doing the battlefield acupuncture and a few other things in the women's clinic, and I can't speak to that because I'm not as familiar with it, and I wouldn't want to misquote it.
Awesome. And then Brian Anderson mentioned in Pocatello, outreach contact could also be made through the VFW DAV and the Veteran Center at ISU. So thank you for sharing, Brian. It looks like, does anyone else have any questions at this time for Dr. Kremer while we have her for 4 more minutes? Give maybe a couple more seconds. If you have
additional questions, you can feel free to email me. I will answer as I can. And if I don't know an answer, I'll try to locate things for you. But also know that sometimes I don't know every in and out of VA procedure and protocols in terms of different things.
Awesome. It looks like at this time we don't have any questions. They do have access to your email, which I included in the chat box. I also put the Empire Idaho newsletter to kind of learn about more of these activities that we're doing. We have another webinar with Dr. Kremer next Thursday, same time, same place, online, and just an opportunity for more consumer focused. But it looks like with no questions, I want to thank Dr. Kremer for your time. This was great, and I definitely learned a lot myself. So we look forward to having you next week, and I hope you all have a good weekend. And yeah, we hope to see you soon at the next webinar.
All right. Thank you all for participating.
Thank you.